Welcome, everyone, to today's webinar. This is Kayla Hayward with the American Hospital Association, and I'm pleased to be moderating today's webinar, Workforce Relief That Works, How Leading Systems Support Clinicians and Performance. Today's event is sponsored by Conduent Health Partners. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by simply typing them into the Q&A box you see on your screen. We like the session to be interactive, so we are looking forward to hearing your questions. If at any time you're having trouble with audio, please try refreshing your browser. You may also submit any technical questions into the Q&A box as well. At this time, I'd like to thank today's webinar sponsor, Conduent Health Partners. Health systems across the country are working to maintain patient access and performance while supporting clinicians who are facing increasing demands on their time. Today's discussion will explore how organizations are rethinking clinical support models to better manage patient needs while protecting provider capacity. We're fortunate to have leaders joining us today who are actively addressing these challenges in their own organizations. Allow me to introduce you to today's panelists. Jackie Lopez, Director of Ambulatory Quality Management at CHRISTUS Health, and Dr. Stephen Kappa, Board Certified Urologic Surgeon and Market President with Urology Group. And moderating today's event, I'm pleased to introduce Dominique Wells, Chief Operating Officer at Conduent Health Partners. Dominique works closely with health systems across the country to support clinical operations and patient access. Welcome, Dominique. I'll turn it over to you now to get us started.
Thank you so much, Kayla, and thank you to the American Hospital Association for helping us bring this panelist together to really have some important dialogue and conversation. We know that today health systems and particularly our clinicians have growing pressures from a variety of fronts, but really, experiencing higher patient volumes. And it's increased as a result of our patients having a multitude of ways to be able to access care today. It can come to us from phone calls, through portal messages, after hours. It doesn't always happen 8 to 5. It may have just general care coordination questions. And so all of these interactions with our patients are so important. And they're often landing on our physicians and our practice leaders who we know are already stretched thin. And so I think, like Dr. Kappa and Jackie's organizations, many organizations are really stepping back and asking some fundamental operational questions about how can we do this better? How can we better support our clinicians while still being able to take really great care of our patients when and where they need it? Because, like I said, convenience doesn't happen 8 to 5, and our patients need our care 24/7. I know many of the leaders who are joining this call, many leaders across the country, are really trying to deal with some of these very same challenges within your organization. So we're hopeful that the dialogue we have today will really offer some practical insights, and Jackie and Dr. Kappa offer firsthand experience there. We're joined by two excellent leaders who have really taken a strong approach in how they're going to support their clinical teams and their patients overall. So Jackie Lopez is the Director of Ambulatory Quality Management at CHRISTUS Health, where she works really closely with her physicians across the entire system and works to drive improved quality, to drive operations and patient access. So Jackie, can you share just a little bit about CHRISTUS Health and about the physician practices you support?
Sure. Thank you. Good afternoon, everybody. So, CHRISTUS Health is a very large, complex system. We have hospitals and clinics across 4 different states. That is Texas, Louisiana, Arkansas, and New Mexico. I'll focus primarily on our ambulatory space. We have over 200 clinics with over 1,500 clinicians that we support, and our clinics are located in both rural communities as well as urban communities. We have a variety of specialties ranging from primary care to women's health to cancer care and orthopedics. And those specialty lists do expand beyond that. And we have the privilege and the pleasure to support our patients throughout their care and throughout their life cycle. So I'm very excited to share today, and thank you all for having me.
Thank you, Jackie. We're also joined by Dr. Stephen Kappa, who you heard is a board certified urologic surgeon and market president at the Urology Group in Ohio. They are one of the largest specialty practices in the country. So, Dr. Kappa, tell us a little bit about your provider group.
Yeah, no, thank you so much, and I really appreciate you all's time on this afternoon to listen in on a topic that I'm extremely passionate about. So, the call burden for physicians. So, just a little bit more about our group and sort of the larger context for why we tried to tackle this problem several years ago in partnership with Conduit. I'm market president of the Urology Group. We are 30 urologists. We have 394 employees. We're in the Cincinnati area. We also serve Northern Kentucky and part of Indiana. But we're also part of a larger organization. Our practice and a practice in New York co-founded Solaris Health, which became from 2020 to 2025 the largest urology practice in the country. And then now we're part of Specialty Alliance and even larger than we were before, also with the largest GI practice in the country, all physician-led and physician-owned. Really proud to be part of this larger organization. But what's interesting is I talked to my colleagues, leaders of the 20 plus urology practices across the country that we partner with. We all have the same challenges. And urology is unique. And just a startling report from the Department of Labor in 2024 showed the challenge specific to our specialty. It said that urology was the most stressful job in America out of 873 jobs that were surveyed. Okay. I think that's a little bit of an overstatement. I do this every day. I think the men and women in the military and those crazy crab fishermen up in Alaska have a much more stressful job than I do, but it's a very stressful job. And all of us who are in healthcare understand that the doctors and the nurses and the medical assistants and all of our team have an increasingly stressful job. But urologist, what's unique about our specialty is an increasing volume of care and services. We have an aging population, the baby boomers. We see this in real life with BPH patients. So we're inundated with patients. We have a number of retiring urologists and not enough graduating residents to fill the need. So this call burden is increasingly burdensome. We felt that. So we did some things initially, and we'll talk more about this as we get to what we did the before and after our system. But just kind of underlying all this is we have a very stressful job urologists do. Burnout is, 63% of urologists in the most recent survey report this. And you look at the causes, it's a whole different webinar altogether, physician burnout, but call is a major part of that problem. So that's kind of the context for the why of why we looked into this particular topic, why we're so passionate about addressing this problem. And the encouraging news for all the listeners, the audience here is we did find a solution. It's not a perfect fix, but it really mitigated the call burden, and our physicians are much happier as a result.
Thank you, Dr. Kappa. Those statistics are interesting, and I'd not heard those before. So thank you for sharing. I'd like to open us up. We want to understand a little bit from our audience who has joined us today. And so if we can share our first poll question so that we can learn a little bit of your insight. So during office hours, thinking about office hours specifically, where do the majority of your patient calls currently go within your organization? We'll give you a few minutes, a few seconds here to
Yeah, so
get
as you guys are,
responses.
we were kind of we're reviewing and discussing these polls in advance, and I'm fascinated to see where this ends up because, a lot of, in our old system, a lot of these calls went directly to the physicians or the APPs, and we were kind of juggling procedures, surgeries, clinic, seeing patients there and phone calls, and we had really busy, overwhelmed staff, MAs and nurses who are doing this, and have changed our system quite a lot over the years, and we'll detail that. But I'm fascinated to see where this ends up for your organizations.
So it looks like 41% are going to the practice staff at each practice. Each practice is managing it separately, followed by 33% are going to a non-clinical call center staff. Okay, that will be helpful as we work through our discussion today. So, Dr. Kappa, I want to talk a little bit about that clinician experience. What are the clinicians experiencing? And as you've talked about, you've seen that significant increase in patient calls, messages, after hours questions, all of those things. From your perspective, how has that really changed your day-to-day experience for yourself and for the providers that you work with?
Yeah, I mean, so to kind of frame this around that survey, the day to day, we have actually a centralized call center that's primarily non-clinical, answering calls during the days, and then they get triaged to the clinical questions get triaged to our MAs and our nurses in our offices. But the day to day for me, it's like I'm in surgery, I'm in clinic. I just finished clinic this morning, saw patients, and I have to focus on that, so I am protected by a whole team. I have a whole team of APPs and nurses and our clinical staff that support what we do. But at night, you're on your own a little bit, right? So what the focus of how I'm going to answer this question is nights and weekends, right? So call and nights. So our nights used to be just we had a simple kind of call answering service with an IVR that, would categorize the call and get the demographic information, and then it went straight to us. And so we get, as a practice, this is 30 urologists, and in Cincinnati, we get 6,000 calls a week, to our call center. That's during business hours. We get 300. You'll see the data in a second, more detail, but 300 plus calls at night, weekday nights, and then on weekends, and a huge number of calls on Saturday, actually. And you'll see that in the data as well. So what's happening on Saturday? Well, it's me, and I also have an APP that helps me on the weekend doing the emergent surgeries, doing the hospital rounds. I personally cover 4 hospitals when I'm on call. We have a system where our physicians break down into 4 different divisions. But no matter how we slice or dice it, we have a huge number of hospitals that we have to cover. We have a significant number of emergencies that come in, the kidney stones with sepsis, those are kind of our emergent conditions. But it is very difficult to deal with those clinical emergencies and answer, routine medication refill calls, or, hey, where's my appointment? I didn't get the address to to your office for Monday. All right, so that's not a good use of time, especially when you're really trying to focus on the urgent clinical needs at night on weekends. So the day to day, I think pre our new call triage system was very chaotic, and we our doctors, if you could see it, when you go into our membership meetings, you could see it on their faces, especially post call. It's like I'm answering a lot of important calls. Patients' calls are important no matter how simple they are. We have a whole spectrum of patient healthcare literacy and other challenges, social and otherwise, they face. So we want to be there for our patients, but how do we do it in a way that allows the physician to focus on exactly what he or she needs to do when they're on call? So the day to day, chaotic is the one word I would use. And it's, you just kind of do the math. It's 300 calls at nights and weekends per week. It's a lot of calls, especially when you're dividing it among a small number of urologists.
Yeah, that's a great perspective and really appreciate your insights there. Jackie, I'd like to pivot this just a little bit. And we've heard from that provider perspective, but let's think about it from a health system perspective. And what are you seeing within the CHRISTUS organization and how that has impacted your providers and patients and all of the things?
Yeah, sure. So we as well have seen a steady rise across all of our specialties in patient phone calls, portal messages, and after hours calls. After hours support is a requirement for many of our payers, so it immediately caught our attention. And we know every patient interaction is important. It matters to the patient, it matters to our clinical staff, it matters to our clinicians, but the cumulative amount of every channel into one was creating burnout for clinicians, but also for clinical staff as well. They were inundated with phone calls and portal messages that were coming in. And as we look across all of our states and all of our specialties, we recognize that we have some operational complexities that are unique to specialties as well and have their own unique demands. And there is local initiatives that are going on to decrease, readmissions in order to increase throughput, all of those things. And when we looked at it, what we saw is that there was a high variability of how our clinics were handling this. And that, obviously puts risk on our organization when we don't have a standard approach of how we handle after a call. So when we took a look at that, we knew we needed to find a great partner that could take all of our complexity and help us streamline our processes, but also in a way that is sustainable, that can grow with us as we
Mhm.
expand our footprint. We wanted to ensure that our partner that we found in Conduit could also grow with us as well. And so that's where we knew we had to take a look to say, what is the next step for us?
Yeah, for sure. And what I'm hearing from both of you is really that burden, particularly after hours, but it's also happening during the daytime hours too, where we're there, providers are being called out of patient rooms and all of those things that just really impact flow and our ability. So I'd like to ask our second poll question, and here we really want to focus on that after hours. So very same question as before, but how are your patient calls being handled within your organization for after hours specifically?
Yeah, this is we have currently two different systems, this call center staff during the day, but this was going directly historically for our group directly to physicians. And that's what we needed to shift. And I just kind of, as people are answering this question, what's the point of all this? I always kind of think we always think about the why of this. And you look at burnout, I kind of mentioned that before, physician burnout, one of the risk factors taking call. What happens as a result of that is all the downstream effects that everybody on this call, wants to avoid. Decreased productivity, for your physicians, for your clinical staff, worse quality of care, double the risk of adverse patient safety events. With a burnt out physician. So to us, that's one reason we took it so seriously is because we could see that. You can see impaired decision making and decreased productivity as a result of this heavy call burden.
Okay. So our results are showing we got about 32% who are currently working with an outsourced partner, and that is followed by 18% either an internal centralized nurse triage or a non-clinical call center staff. So that's great insights there. Okay. Um, Dr. Kappa, as you talked about that kind of nighttime burden and what you were feeling and experiencing, can you share, and you kind of described this already, but that night and weekend and what that really looked like and for your physicians, that overall impact. Can you talk just a little bit more about what that was like from a work-life balance and a just quality of life overall?
Work-life, that's the word that everybody likes to use nowadays. I like to think of it more as work-life blend because when you go
Yeah.
into medicine, I'm a surgeon, and it is it's a calling, and what we do demands a lot of our time and energy and effort and a sacrifice of some of those things that are part of that balance. So. What I kind of try to think about is, what are the things that we can. So, to answer your question, chaos, it was chaos before. It was stressful, and we all want to work hard. My
Mhm.
partners and I, we want to see patients. We want to tackle the complex cases. We do a lot of robotic surgery and complex surgery. We love doing that. That's what we trained for, went to residency for. But the thing that you don't train for is the wear and tear over years. I'm pretty young in my career. I've been doing this for 9 years since I graduated residency in 2017, and but I can even feel the effects. And I talked to some of my senior partners, and what I worry about most actually is the effects of this call burden on the prompting the early retirement of physicians. So you hear
Mhm.
about, pajama time. This is like the term that we use, and we've pulled it with our younger physicians. It's, on average, depends on what study you look at, 90 minutes a day, pajama time, 1 to 3 hours in our experience. And this is a huge burden on our physician, really related to the EMR. But you compound that burden, which nobody's figured out the EMR problem. If you have, please raise your hand and tell me how to fix that. But so the EMR problem is what it is, and we're working on a lot of technological solutions there. But the call burden is something that you can really tackle. And so
Mhm.
before we were running around like chickens with their head cut off, however you want to describe it. I welcome anybody to come to Cincinnati be on call with me. But you can see, I mean, it was remarkable. You're running to the OR to do a stent case for a septic stone, and then you get a call again about the Flomax refill. This is a real story. Or worse than that is it's 2 a.m. You just had a long day. You did 3 add-on cases on a Saturday. You get home,
Mhm.
hopefully have dinner. I have a 9, 7, and 4-year-old. I love to try to make it to family dinner as many times as I can. And then you get a call in the middle of dinner about a Flomax refill or the 2 a.m. phone call, for just a really non-urgent clinical need that disrupts your sleep cycle. I'm obsessed with sleep because the more older I get, the more important I know it is. And when you look at the sleep data, there's no doubt. I mean, there's a reason airline pilots really care about this, and you can name other professions. In healthcare, we've not taken this as seriously. And so I know as a result of us changing things from this chaotic sort of physician only triage, that we've gotten better sleep, better quality sleep, and that makes a big impact on our quality of life, on our
Mhm,
work-life balance as well.
mhm. Yeah, I mean, all that you're saying, I think that resonates for everyone who's on this call and who has worked bedside, whether it's a nurse or a physician or, just any clinician within the healthcare space can relate to what you're talking about. So let's talk a little bit about what was the difference that you saw once you implemented the nurse first triage strategy? And I think you actually have some data that you wanted to share around this.
Oh yeah, Jackie, is there anything else you wanted to add there? And I'll well, you can jump in on your experience, kind of the pre-post, and then we can look at some of the experience we've had since we changed to this call triage system.
Yeah, I'll just say, I think the pre and the post from an administrative standpoint, there was some hesitation from our clinicians of having someone outside of their clinic take call and talk to their patients. So we did meet hesitation, initially skepticism, but post now those same clinicians that were initially skeptical, they are some of our biggest champions for when we onboard new clinicians, letting them know how great it is to be on call and maybe not receive a call every time, right? Because of the nurse first model. So we really have utilized that data as a talking point with our clinicians when we introduce how we handle after hours call at Christus. And so that has been our experience.
Yeah, well, I can. Yeah, so just to kind of give a little background before I'll share our data. So this report has evolved over the last year or so. We were the first urology practice to join Conduit Health and to partner with them to help us. But really, just kind of that Jackie, I appreciate that point. It was actually a pretty easy sell for me to go for the group. Hey guys, do you want less, calls at 2 a.m.? Yes, sure, whatever that takes. But no, I mean the emphasis on clinical quality. So we want to make sure that this process still supports high quality care for our patients. Okay, so the system that we have is a nurse triage system, and it's protocolized with the Schmidt-Thompson protocols. This is something that is evidence-based, and it goes through, if, for example, we in urology, we have a lot of, as you'll see in a second, a lot of urinary problems. Patient calls in with gross hematuria. I've got blood in my urine. Well, there's a very protocolized triage for that. Is this gross hematuria that requires an ER visit, or is this something that can be seen in a more elective outpatient basis, the next day in clinic? So it's very protocolized. It's well done. It can be done efficiently too, as you'll see in terms of how long that call takes. But let me pull the data up because this report, I'm excited to share it. This is actually hot off the presses. This is from this morning. It's like this is great timing. So we get these once a month. Myself and our hopefully everybody can see it. It'll pop up in a second. So this is our report, and we've been working on this for a long time to uh, find out what matters, what metrics matter, and what can we learn from this? How can we continue to improve the system? So all my docs, all that we care about is this far right. Okay, so there's a lot of data here. You can get really, I'm not going to bog down too far into it, but percent of clinical encounters, clinical calls that escalate to the doctor. So you can see in the last couple of months, 4, 5, 6%. So 95% of our calls are being triaged appropriately that don't transfer to the doc. Historically, we were a little bit lower than that. It was like 70, 75% were answered, and we get more of them. But we learned over time, we changed a lot of our protocols in ways that were appropriate. This is just kind of back and forth with the conduit team to say, hey, well, this patient calls in with this concern. That's okay. Well, if you're going to direct them appropriately to the ER, you don't have to call us, at 3 a.m. to say, hey, I've got a kidney stone patient who's going to the ER. The ER will contact us. We have good relationships with our local ERs. They know when to call us. So you don't need to wake us up to say, I have a patient who has an emergency. That will be handled by the ER. So a lot of back and forth, and we're really actually proud of this number. And this is the thing that, we show this to our doctors. They basically get up, dance, and celebrate, but they can feel it on a day-to-day basis on their call. You can see on the left here, so this kind of goes to the data of around 300 calls a month. So calls handled on a per month basis here. So 300. Okay. So this is the nights and weekends. And you can see actually in the middle here of that graph is the call handle time. What's the average handle time? So if you extend this out farther to the left, it was actually much higher than this. And this is one of those things with experience with the subspecialization, the nurses getting more familiar with urology patients. We did a lot of back and forth education of the types of clinical problems that we deal with and some of the nuance there from our perspective, the physician's perspective. So you see how that's steadily gone down. We've really worked on this, and this is a cost concern. You know, the cost is a per minute basis. And so we wanted to really make sure that the patients were getting good care, but it was done in an effective, efficient way to meet our budget. We had a very specific budget for this. So this just shows you again, the calls are escalated, the average calls handled. I'm going to go down to the second page again. I could talk about this all day long because there's a ton of interesting data, but I wanted to key in on one point. You know, one is the redirection rate. So ED avoidance actually and redirection rate. That means not going to the ER, but here's ED avoidance. This is a really important one. So these are called, we actually we've shared this with our hospital partners too, and our payers. We've invested in this process to avoid unnecessary ER trips. You know, when they're appropriate, they're appropriate. We need those patients to get emergent care. But this, I think this is really impactful from a patient experience and a patient care standpoint. The last thing I'm going to point out is this top 5 concerns by disposition. Okay. So we were really interested in, and we've done this kind of during the day, is like, why are patients calling? Is it to change an appointment? Is it to get a medication refill? Is it for a clinical complaint? Well, most of these, you know, there are some administrative calls at night, but most of these night and weekend calls are clinical concerns, and you can see how they're broken down: emergent and non-emergent. Urinary concern, this is the classic Foley catheter problem, flank pain, kidney stones, you know, post-op concern, abdominal pain, scrotal pain, and swelling. We've taken this and then rethought how we do patient education from a post-operative standpoint. So when our patients leave our surgery center or they're leaving the hospital, we're given the right instruction. If we see an uptick in this, it points back to maybe we're not doing enough education at the time of that surgery or in the preoperative counseling of that surgery, because a lot of these questions can be answered in advance or with appropriate patient education materials. So we look at this every month. We review it. We do it in collaboration with our friends at Conduit Health. But you can see that the really the most important thing is 95% of these calls are screened. That's again time that our doctors can get sleep, get rest, and recovery after a busy day in the OR when they are on call that night. And we've learned from this clinical data to inform our patient education efforts.
Yeah, and I love how you're using the data to really help drive and inform kind of what's our next step? Like what's the next thing that we need to do to really make sure that we're streamlining it. So it's giving you lots of insights that I'm happy to see that you're able to use those in different ways. We did have a question that came in to us prior to the webinar. So I think this kind of ties in a little bit to what you just talked about, Dr. Kappa. And what the audience member is asking is, from your experience and within your provider group, did you have any providers who had very specific instances where they wanted a triage patient to end up in the schedule, or based on that triage disposition, it's either ED, urgent care, or maybe be seen tomorrow or within 3 days. If they were placed on the schedule, were there certain blocks that they wanted to utilize? Or once they were placed on the schedule, did you find that you were canceling because you, as the provider, actually know the patient well and decide that the patient doesn't really need to be seen? So they're just asking for your insights around that.
Yeah, Jackie, you can jump in first on that, and then I'll answer.
So, we support many proceduralists here at CHRISTUS, and there are certain things that we like streamlined and standardized because that just creates efficiency for the nursing team, but also for how we onboard new practices and new providers. But there are certain instances where we do feel like the clinician having some autonomy, especially on patients that they know well, is helpful for the patient experience and the clinician experience, which then drives the good health outcomes. And so the way that we do it at Christus is if there are in a kind of isolated fashion clinician preferences, then we do allow that autonomy to happen and we aggregate what those preferences are. And so that way the triage team has quick access to that and that we keep physician engagement and satisfaction, but we also are ensuring that patients are getting the right care at the right time and at the right place.
Yeah, just we similarly have we call it like a little wiki, but our call center and our scheduling teams have doctor preferences, and so if it is one of their patients, if it's one of my patients who ends up in the ER and needs follow-up, I mean, of course, I want them back in my clinic. In urology, we don't get a lot of feedback. Hey, I don't want that patient in my clinic, or I need to schedule because so many of these are hands-on exam, like managing a Foley catheter, looking at a drain or examining a post-op wound. And we've got a pretty well coordinated system with APPs that will see some of the less urgent issues, but we haven't had a problem with negative feedback as to how these patients are placed. A lot of that's because the currently Conduit's not scheduling patients in our practice management software. We kind of actually talked about what's the next step in evolution. I mean, I'm really passionate about integration of systems, EMRs, ours versus the hospitals versus the call center triage. I mean, you go on and on. How all these systems don't talk well together. They don't. If somebody has a perfect solution for full clinical integration, please raise your hand. Let me know. I'd love to learn from it. So what happens is there's a handoff in the morning from these overnight calls and scheduling requests that go to our primary team. So and they handle it according to the physician preferences that are stated in advance.
That's great. I think I'd like to take it back to our audience again, just based on the conversation that we just had and hearing some of the operational changes that both of you were able to implement. So if we can ask one more poll question here, we'd like to understand how have you made any operational changes based on patient call patterns within for those of you who are operating a centralized nurse triage or a call center of some sort? Because like Dr. Kappa and Jackie have shared, we like to learn from others as well, to be able to gain insights because we're constantly having this dialogue and this conversation around what's next and how can we continue to do this better.
Yeah. If you say no, I would challenge you to go look at it again because you could definitely learn something from this. And I have one actually really specific example as people are finishing this. So absolutely, and this isn't necessarily related to the night and weekend call triage system that we have, but it is because a lot of those calls are kidney stone. So there was a comment too in the I'm going to try to get two birds with one stone here. There's a comment about sharing this data with payers is very impactful. Yes, yes, yes. And here's actually a very specific example that we did engage payers with, but they love to see these types of systems that avoid the ER because that's a tremendous cost savings for everybody. It's better for patients, it's better for payers, it's better for us. But we took this data, we saw a ton of kidney stone patient calls that were not emergent, not the septic stone that needs, emergency surgery that night. But I've got a kidney stone, but my pain is stable. But, I don't want to wait a month to see a urologist. So we took this call data and particularly the kidney stone calls, and we actually hired a specific nurse practitioner to manage we call it our stone triage line. So kind of have a separate disposition for stone patients. These are, I don't know if you've had, you can raise your hand. I don't know if you can on this Zoom here, if you've had a kidney stone. If you have, I know you're going to relate to this. It's the worst pain in your life. Okay. So I've had patients who have had children, and they say, I can't say this obviously, but it's worse than delivering a baby as delivering a kidney stone. So this is like the worst pain of a patient's life. And so you get a call, you present to the ER, you get some pain medicine, you get stabilized, but you don't want to wait for a long time. So we hired specifically a nurse practitioner to triage our stone clinic. We worked with our ERs to say that all those patients get next day appointments really no matter what. We built in slots for both our doctors, our APPs, but specifically for our APP who was leading this stone triage, and she gets to all of them the next day. These patients get telehealth appointments and then they get rapidly triaged. I'm from the time that a patient goes into the ER, like let's just play this out for a scenario that probably happened to our doc on call tonight. It's not me, but patient comes in the ER at 6 p.m., nausea, vomiting, stone. Okay, they get appropriately managed by the ER team. They get their pain medication, they get their fluids, they get their imaging. Okay, this is not emergent, but you need to see Dr. Kappa, very soon. Okay, here's the number to call. Okay, so they call the next morning. It goes to our stone triage line, which we learned from this after-hour call burden and experience. And then they get same-day appointment telehealth in the morning. We tell the ERs to tell them to stay NPO, and then they're at the surgery center with me at 2 p.m. and they get their ureteroscopy. So we have literally less than a 24-hour turnaround from stone presentation to outpatient surgery and home and stone is out. Now
Yeah.
that's best case scenario. It doesn't always happen that way, obviously, but we've changed our system to address that kidney stone care need, and it's really been tremendously impactful for our patients.
Yeah, that's a great example. And it looks like, 55% of our audience has actually used the data to help implement changes. But for the, what, 20, 30, 45% that have not or have identified some opportunities and haven't, hopefully they're learning from what you and Jackie are able to share today. Um, hold on. I apologize. I'm having a technical difficulty here.
It's okay. I can jump in.
Thank
Maybe
you.
share
Yeah.
how we've utilized data to drive some of our decision making. So, data transparency is huge with Conduit. Sometimes the data can be like, okay, I can't process all of this at once to know exactly what's the best next step with it. But what we noticed across our specialties is that there was high variances in call volumes and call day, but where there was just very discrete similarities is that our call data spiked before clinics opened and then spiked again right when clinics closed. And we all know kind of what that means, right? The patient's going to go on their patient portal and send a message, and that's going to create rework of people knowing that they called, also sending a portal message. And so what we've been able to do, where we've been able to isolate where those high volumes are, is have clinics adjust hours, but centralizing that, right? So not every clinic has to open early, but we can kind of tee in different clinics in surrounding areas to open early or stay later. And what that does is
Mhm.
that increases patient satisfaction. So when they're calling their proceduralist, they can get their appointment rescheduled or they can get it moved. Conduit actually has full access to our EMR, which has worked really well for us, meaning that they can schedule primary care appointments to us. It is a closed loop for our clinicians that they see exactly what protocol was utilized and exactly what was told to their patient. So they're completely acting as a member of our care team. Our specialists have not quite given us that full access to scheduling because we know scheduling with specialists
Mhm.
is complex and there's very many factors that go into that. And so we are not there yet. I think we're on our journey there to demonstrate the value of having Conduit take care of the patient so that way that patient doesn't have to call back the next day and have that full experience when they talk to a nurse.
Yeah, Jackie, thank you. I apologize. I lost my screen there for a second, so I couldn't see everyone. So Jackie, as you talked a little bit about, those operational, the visibilities, those improvements, the things that you've done, can you talk a little bit because one of the things that we hear leaders talk about is, okay, it's great that we put this centralized model in, but what happens when we have these surge in call volumes or we have these unexpected events? So you have some real life scenarios. Can you share a little bit about that?
Yeah, so the states that we serve in, we have some pretty unpredictable weather events that can occur, whether that is a hurricane or a dust storm or a sudden ice storm. And those can disrupt our operations pretty unexpectedly and quickly. During our first major ice storm that we had experienced right after going live with the centralized triage model, there was a big outage. Roads were closed, clinics were closed for a lot of days, and we saw a surge of call volume. That was really a turning point for us because what that surge exposed to all of our leaders is that how we communicated clinic closures, how we dealt with appointment cancellations, there was some variability in there and some unclear expectations to patients. And thank goodness our conduit partners were able to absorb that call volume for us, but it wasn't a great experience for anyone. And so by taking a step back, working with conduit, analyzing that data, we were able to come up with some good operational practices of how we can handle closures consistently across our system. The same message patient will receive on their portal, the same IVR when they call a clinic and it's closed. And what that has done is positioned us to survive other storms that have happened since then, but also let us all have the peace of mind that when these things happen when they do occur, even when you have, a outage of power, those happen too that are unplanned, that we know what we're going to do and we have the right partner that's going to do it with us.
Yeah, and I think that's the important thing, Jackie, is really having a partner who's willing to think about and work together and really dive into where we can make some true changes and true impact for your patients. We did have another poll question. I think this one is, I'll direct to you, Jackie. The question is, how did Christus use the data and measure success with this operational shift? And what did you look at from an ROI analysis to, as you were starting to consider standing up and then as an ongoing, forward ROI capture?
Yeah, of course. So standing up a triage center, it is a significant investment, right? It really is. I think what was important for us is to understand what was important for our stakeholders. So what was important for our operation leaders as well as our clinicians. The way that we have measured a to be successful is really broken up in a couple buckets. The first is what Dr. Kappa has talked on is clinician engagement, clinician burnout. We have various surveys that we send out throughout the year for our employed clinicians. So we're capturing that and monitoring that and saying, well, are they using our centralized service? Are they not? The second is also clinical staff, their engagement, because burnout is both on both ends. It's clinician and the staff as well. And we know that there is a cost to all turnover and all recruiting and all retention. Third is how we are doing with our payers. What is our quality look like? What are our scores? How are we positioning ourselves for fully transitioning into that value-based model? And so making sure that we had great ways to do that. And then the last bucket I'll touch on, and Dr. Kappa touched on this too, is our ED avoidance rate. So I'm proud to say that we have a 90% ED avoidance rate at CHRISTUS Health when they utilize our centralized call center. We know that ED visits are costly to the patient, they're costly to payers. And so that is something that we are always looking at of how we're measuring that. I'll end with just a little story here to this question that just recently happened as of this week. So our conduit health partners told us that there was a patient that's been calling them often, quite often, actually. I think it was about 250 phone calls in the last couple of months. And so what we looked upon is that patient had actually declined our care coordination services that we offer at Christus. And but when we looked at the patient's chart itself, it looked like they were also visiting the ER frequently. So when our care coordinator team reached back out to this patient, they felt comfort going to the ER. They felt comfortable knowing that they had somewhere to go. And so what we were able to do is just educate that patient that you can call our triage services, but let's also explore nurse navigation with you. So that way we can talk about how we can truly coordinate your care and not have to utilize the ER every time. So I just think that that is truly the return on investment story of that how we can partner with someone that is also looking at those things with us. We didn't ask Conduit to give us that information. That's just something that came across their radar. And as a good partner, they wanted to share with us. And we both have that mutual trust that when we share data and we share stories, there's going to be action taken. We may not be able to do something immediately, but it will be constantly on each other's minds to think about how we can be a better partner to each other to have the ultimate clinician experience, associate experience, and the patient experience.
Jackie, that was a perfect segue into my next question, really around how, working with the triage team and doing that. Dr. Kappa, do you have any additional examples that you would share around the partnership?
Well, the ROI thing, I care a lot about that. And some of these things are a term I like to use is spreadsheet derangement syndrome. Like we can sit and build a pro forma around this and look at the numbers. But as Jackie was mentioning, there's a tremendous ripple effect to a burnout, exhausted physician on your financials. So if you want to build a financial model around this, you can, and we have, and we looked specifically at the post-call docs, what they do, usually on the Monday or Tuesday afterwards. Some of them had to literally had to take a whole day off to recover from a busy call weekend. And so we look at it in terms of clinical productivity, and we've been able to see some benefit there. But Jackie talked about turnover organizationally, how expensive and costly that is. We talked about the medical errors and other problems associated with burnout. So, you can do an analysis on this. But I actually asked our docs at the when we were doing this project. We had a budget for it, and so we don't, by the way, triage all calls. These are just patient calls. So the calls from the hospital still come directly to us. So we said, okay, well, we want to like, what's the highest impact? The best bang for our buck, and we focused on patient calls at nights and weekends. So that's how we defined the project. We set a set budget for it. But I asked our docs, I said, if I had to tell you that you never had to get a call in the middle of the night for the rest of your career, unless you were doing an emergent surgery that was necessary, as a urologist to take care of that septic stone, like what size check would you give me right now? And it was fascinating. People, I mean, a lot of the docs almost said blank check. I mean, not really, but we're an independent practice. We invest in this ourselves. The physicians are directly
Mhm.
paying for this, and we thought it was absolutely a worthwhile investment. And you can see it in the bottom line financials. I mean, you have a healthy organization with physicians and staff who are rested, who are energized, who are eager to come to work, who are not burnt out. It translates to organizational success and profitability. So I care about ROI, but I also kind of don't. And it was just kind of funny how, especially the younger doctors, are more interested in, and a lot of them, actually, a lot of our docs are two physician households, right? So
Mhm.
many of our urologists, so they're juggling so many things. I got a 974-year-old again. If you told me you had to write a check to not get that call so you can be arrested for your son's, track meet, on Saturday, I would definitely invest in that. So, I mean, there's a lot of ways to look at this, the ROI analysis, and we did, and we take that very seriously. But I would not underestimate for the leaders on the call. I would not wait to get a really depressing physician burnout survey. I would not wait to see turnover numbers that start trending in the
Mhm.
wrong direction because you're not paying attention to these concerns for your frontline physicians.
Yeah, what I love about what both of you have shared is that you've really focused on strengthening and supporting your clinical resources, your clinical teams, your physicians, your practice staff, et cetera. And so I think that's really the key point that I've taken away from our conversation today. And on top of being able to use the clinical insights to make really good, practice decisions, really good patient decisions around how we are treating our patients and how we help educate them and all of the things and the ways that you guys are implementing the data or using the data to really drive change within your organizations. I want to thank both of you, Jackie and Dr. Kappa, for being here today. I would like us to be able to have some time for some Q&A. So I'd like to turn it back to Kayla, and she'll go through a couple things around Q&A, and then we'll dive into any questions that folks might have.
Great, thanks, Dominique. Yes, we'll now begin the Q&A portion of today's event. As a reminder, you may submit your questions to our speakers in the Q&A box on your screen. Simply type your question in the box and hit submit. Our speakers will answer as many questions as possible in the time remaining, and any questions that are unable to be answered within our allotted time will be shared with our speakers for follow-up offline. So now I'll hand it back off to you, Dominique, to kick us off.
Okay. Well, while we give folks a second to answer any questions, I do have a couple that came in that we can maybe start with. So, Dr. Kappa, you mentioned that you initially said 75%. You just highlighted that your most recent data is really showing closer to 95% of those after all hours calls are being handled without escalation to a physician. How did you really build trust with the physician group that patients were still being well cared for, or was that even a consideration for your practice?
Well, yeah, no, I mean, it absolutely was. Again, it's an easy sell to my docs if you're tired. It's like anything you can do to mitigate the call burden. Of course, we care about patients and
Mhm.
we want to make sure that they're getting their concerns addressed, and if they're emergent. What we did is we engage with our office managers. They kind of hear a lot when there's a patient problem, a patient concern. We do surveys and everything, but we get immediate feedback every day in the clinic from to our nurses, from our patients, to our doctors, from our patients, and our managers will get the calls. And so we monitored very closely. Are there complaints? Are there issues related to this? We engage with our ER partners. Hey, are you guys having any problems with inappropriate directions of patients coming to the ER? So we monitor that, whether we're issues here and there. I mean, we actually had monthly calls, at leading up to the flipping the switch to the conduit help team, but we had debriefing, the month one, two, three, four, and you've seen how it's grown over time. I showed kind of the last year. We've iterated multiple times in sort of how we've triaged calls, and we've informed and influenced not the protocol. The protocol is the protocol. We didn't change that, but we changed the IVR, on our end to help better answer some of the administrative calls. We provided education to the nurses, and when there was a feed, I mean, I can think of a couple of emails we got where a physician had a concern, hey, this patient was directed to the wrong place or got the wrong advice, whatever it was. We're not 100% on everything, and we gave that feedback back to you guys, and you immediately addressed it with your team, educated your whole triage team. And so it's like any process when you implement a complex project like this. We would have monthly follow-up calls with the conduit health team. We had physicians engaged at every one of our membership meeting and solicited their feedback and told our managers, keep your eyes out for any problems and let us know. And so when we got that feedback, we sent it directly to you guys, and then we haven't seen really major issues since then. And I would actually say again, the going from the 75% to 95% it took many months to get there. And that was just, we would actually tell our docs, hey, if you get a call escalated to you that you didn't think was appropriate, literally email me, email our CEO,
Mhm.
email, the physician leads on this project. Dr. Bay was one of our docs who really took the charge and implemented this project. He's the chairman of our board. He was personally very passionate about this. And so we had a physician champion in Dr. Bay. We had myself engaged, our chief medical officer, Dr. Edwards engaged. We were all very engaged on this project from the very beginning. And so we took that physician feedback right back to the conduit health team and kept the communication lines open.
Yeah, well, I think it's important in building that trust is showing that they have first of all, creating a venue for them to be able to actually provide feedback and then seeing action as a result of it. So it just can't sit idle and can't continue to see the same things over. I think that's a really great point. We do have a live audience question, and it's the old AI question that I think all of us are talking about in our own organizations. But what are the two of your thought around the use of AI to facilitate most of the triage?
Jackie, you can answer first. I have a long answer. I'll talk all day on this one. Go.
I'll just say, as the health system, Christus, we have some governance around AI and we are, exploring and looking. But when it comes to a true emergency, there is nothing that's going to replace a nurse's ability to triage on the spot and to get the right patient in the right place. I do think there is lots of even predated AI things such as Google Doc and those items. But when a patient is in need and a patient is truly having an emergency, they rely on that clinical guidance of a real person to guide them where the right care needs to be. And we have seen that with our patients. I'll also hit a little bit what Dr. Kappa was saying about the age of our phone calls. We look at age complexity of who utilizes our after hours nurse line, and the majority of the patients that are calling in is that managed care population, that older generation. They are our high utilizers. And,
Mhm.
honestly, I don't know that they would be open to utilize AI. And that's the way that we look at things, is that as long as there is a demonstrated need of our population, we're going to continue to meet that need.
Thank you, Jackie.
Yes, we're urology, so we have a lot of the old guys with catheters who have some cognitive issues, and so their ability to use even phone-based application. We've tried all sorts of things in our clinical practice. Man, I would just say to start, AI is going to absolutely revolutionize what we do. There's no doubt about it. We're currently a part of two AI pilots, not related to this specific call triage question, but we're looking at inbound and outbound communication generally. How is that done? There's some really, I mean, the leaders on this call, I'm sure, know, and you probably get inundated with requests. We have our chief information officer just has like a bazillion emails a day about this
Mhm.
stuff. So we have a committee at a national level with Specialty Alliance and some really innovative leaders there who try to triage these products. There are call answering services, and we're piloting currently three, looking at three. We haven't found the perfect solution, but to echo Jackie's comment, I think especially for a lot of our patients who have trouble even just clicking on the IVR prompts, having speaking to a person and getting directly connected to one of our in person patient care experiences will be to a phone call anytime or a or automated phone call anytime. Now, again, I'm not naive to the fact that we're going to see just rapid innovation in this space. And I think it can be done in a way that better serves patients. I mean, we have only, I mentioned we have 394 employees. We get inundated with calls. And so in some ways, like we're not serving the patients the best we can. So I think about technology as leveraging the
Mhm.
existing people and the talents that they have to better serve patients. That's how we're looking at it right now. Again, there's a ton of hype in this. We're focused on AI as in terms of ambient AI scribes, in terms of evidence-based pathways. There's some really awesome tools. Again, I can talk about this a whole different time that are helping our in real time clinic decision making for APPs and docs. And then we're also looking at automated clinical medical medication refills. That's what we're looking at right now. So there's a lot of ways to leverage this technology. There's no perfect solution. There's a million companies out there doing this, and we're engaged with several of them and piloting currently an ambient AI scribe that does some of these inbound and outbound communication tools synced with the EMR. So it's kind of a wait and see approach. We're really thrilled with the RN triage right now, and the patients have given us really good feedback to their experience. I mean, I'll interested in what Dominique says about this too, because
Mhm.
I think that we have so many experienced people, but they can, as we've talked about today, there's turnover in our organizations. It's hard to keep really good people. There's life happens, people don't show up.
Mhm.
How do you use your existing resources and not stretch them too thin by leveraging this technology to enhance that communication to patients? So that's maybe a long-winded answer, but I could not be. I'll tell you this: my physician partners, specifically my partners who are near retirement, are like, Stephen, you're just entering this age where finally technology is going to help you instead of burden you. The EMR era has been a disaster for physicians. It has been horrible. You look at the time spent in our EMR
Mhm.
systems compared to my mom and dad who are retired physicians who had mostly paper charts. It's been a disaster. It's been great in other ways in terms of research and integrating systems in ways that can really help inform patients and inform physicians taking care of them. But I think that this next wave of technology is going to really help the nurses and doctors, the people on Jackie's team, to better care for patients. So I'm excited about it. If anybody has the perfect AI solution for inbound and outbound patient communication, please raise your hand. Let me know. I'd love to use it. We're exploring many right now.
Yeah, I appreciate both of your response there because obviously AI is top of mind for everyone. And really, I think there's a true balance in being able to say, how can we maybe perhaps instead of the IVR, leverage as those calls are coming in using AI technology to gather some pre-information that helps us best care for the patient when they come. And I always call it, I kind of think of it as like the ripcord, to your point, having a live person who can help offer reassurance, guidance. We're now going to have the capability to launch a video visit where I can actually see the individual because we have examples where mom is calling, baby is, you can hear the baby heavy breathing, and we just need to lay eyes on this baby to make sure that we're making the right determination and or as increasing our disposition reaction. So that's the way we're kind of thinking about AI. But Dr. Kappa, you're 100% accurate. We've got to look at how do we make sure that we drive efficiencies for our clinical resources to be able to take really good care of the patients. So how are we teeing up the urology group specific protocols and the way that they want their patients managed? And Jackie, for you and your team, and we know how complex the CHRISTUS health system is, and really being able to decrease that mental capacity for our clinicians so that they can really get to the heart of what we're trying to do is take care of those patients. So thank you for that question. I think that generated a lot of dialogue, and obviously we know AI is a hot topic in today's healthcare world. So we appreciate that. I know we're getting close to time. Just we've got like 2 minutes left. Jackie or Dr. Kappa, any last minute comments or that you'd like to make?
Go ahead, Jackie.
I'll just say, for anyone that is considering having a centralized triage system, listen to your stakeholders and have them be your champions along the way to design your workflows because at the end, they're going to be the ones that sell it to everybody else. The work will speak for itself, and you won't have to do anything after that. So that would be my closing remarks to anyone considering doing this, is to really identify who their true stakeholders are, obviously physicians, obviously operation leaders, and involve them in the process.
Mm. Yeah, I would say just, don't wait. The thing that surprised me most, I mean, when we show the data to you, is 5% of the calls we receive do not need to be answered by a physician. We were burdening our docs historically with that. We did this in a cost-effective way. I think it's going to become even easier in the future with the technology that is just on the horizon. Again, I could not be more excited about practicing as a urologist. I'm actually getting a page to go up and do a vasectomy upstairs here. I got to leave in a second. Their patient's ready. They're getting their vasectomy. Sorry. But no, I could not be more excited about the future. I think that our physicians, our nurses, our nurse practitioners, our physician assistants are going to be able to leverage this technology, be supported by these types of programs and projects and I hope is ultimately my hope is that burnout number we cited at the beginning, 63% of urologists, these
Mhm.
really this terrible data gets better with time as we figure out ways to implement this system and many others like it in the future. So I'm excited about it. I'm happy just as an open invitation. I'm happy to follow up with anyone afterwards. There's many questions I know that were unanswered. Please, I think they can provide our contact information afterwards, or you can connect with me online afterwards. I'm happy to engage with any of the leaders on this phone call today. Thank you for your time. Hopefully, it was worthwhile. We really appreciate it and are honored you came in and hear what we had to say, and hopefully, it helps your organizations.
Well, Jackie and Dr. Kappa, thank you again. I'm going to hand it back to Kayla to let her close us out. And we hope that everyone got some great insights, and we will be sharing some additional data and all three of our contacts if you have any additional questions.
Great, thanks, Dominique. Yes, that does conclude the time we have for questions today. I would like to thank both of our panelists for their time and excellent presentation, and also Dominique as well for moderating. And thank you to our sponsor, Conduent Health Partners. To learn more about the content presented here today, please check out the resource section on your webinar console and complete the post-webinar survey. In the next few days, all attendees will receive an email that will include a link to the archived webinar session. We thank you again for joining us. Have a great afternoon.
Thanks all.
Bye.